My name is Kyle Gettle. I'm the nurse clinician for the Amputee Rehabilitation Program here at Parkwood Institute, part of St. Joseph's Healthcare in London. If you are watching this video, it's likely that you're waiting to have an amputation or you've already experienced one. And for that, we are truly sorry because we recognize that this is a life-changing event not only for you, but for those that are close to you. When you come to our clinic, you'll meet some of our other team members. You'll meet a physiatrist, that's a doctor who specializes in physical medicine and rehabilitation, a nurse, and a physiotherapist. You may also meet someone called a prosthetist. It is a prosthetist who ultimately makes an artificial limb. A lot of people don't know that, and that's okay. You'll learn more about that when you're here. If you don't have a preference of prosthetist, one will be randomly assigned to you when you come. When you come to the amputee clinic visit, you're going to come and park in this parking lot. It's parking lot number 3. You pay by credit or coin as you enter the parking lot. Over on the left side is the entrance to the outpatient amputee clinic. And this is where you're going to come through and meet myself and the rest of the team. So this is one of the rooms that we use to meet people who are thinking about getting an artificial leg. This is where the assessment is done. It's important to point out at this point that not everyone goes on to get an artificial limb. Some people find they can reach all their goals and do everything they need to do in life from the comfort of a properly fitted wheelchair. Other people may not get an artificial limb due to things like being medically unwell, unable to get to a standing position on the leg that they have, issues with the remaining foot that would stop us from putting weight through it, and impaired memory, just to name a few. A lot of people don't realize how much energy it takes to use an artificial leg. For instance, this below-knee prosthesis, for someone to use it, it requires 50% more energy than whatever it took to walk before the amputation. Somebody who's getting an artificial leg for an above-the-knee amputation, they use up to about 100% more effort to do the same walk as they did before. So you can just imagine, for some people, that might be asking a little too much when a wheelchair might do exactly what they need to do in a more efficient way. Getting an above-knee prosthesis does not help with transfers, such as getting on and off the toilet, in and out of a car. It just doesn't do that. A below-the-knee prosthesis might help with transfers if the person is feeling well. So what I'm trying to say is that getting a prosthesis doesn't necessarily make things easier. So what typically happens after your amputation while you're still in acute care hospital? Your team will send us a referral, we'll receive the referral, we'll send back an appointment, time and date for us to meet in a room like this. Your team will also be trying to get you to become more mobile at the bedside after your surgery. They'll get you to do things like transferring and doing things for yourself, standing and transferring repeatedly. They'll also might try and get you to do some hopping. We recommend that people do not hop very far on their remaining foot, partly due to balance and partly due to the fact that we think of that remaining foot as the golden foot. We don't want harm to occur to it. If people have diabetes, they are especially prone to have injuries if they have a lack of protective sensation. So we would encourage you, if you have diabetes, to ask your team to perform something called a monofilament or 10-gram monofilament test. It's painless. It's a little piece of plastic that pushes up against the bottom of your foot. It's a score out of 10, and it gives you an idea of how risky your foot is for having harm occur to it. Statistically speaking, people who've lost one limb due to diabetes will lose the other one within 3 to 5 years. But there's a lot that you can do to change that. Part of that is just becoming more aware of your own body and knowing the risk of amputation. The 10-gram monofilament test gives you some insight into that risk. When we meet, we're going to ask you the same questions you've been asked 100 times. We're going to do it 101 times. We're going to ask you about your general health. We're going to ask about your independence. How are you able to look after yourself? And we'll actually get you to stand on your remaining foot while you're here to show us what you can do. We are interested in whether or not your knees are contracted or your muscles are too tight. There are a lot of things that we look at. If all the boxes are checked off, that everything is complete and satisfactory, then your name goes onto the waiting list. Don't be afraid of the term waiting list. Ours tends not to be very long. When your name comes up, a call will be placed to ask you to come in and start your program with us. Sometimes people need more time. Sometimes it's a case of finances, or there are social issues that they need to take care of first before they have the time to come in and start the program. And that's okay. You won't lose your spot on the waiting list. We will call you when the next opportunity arises. A word or two about costs of prosthetics. The Assistive Devices Program of Ontario, or ADP, covers most of the cost of what I would say is a basic artificial leg. Something that safely gets somebody from A to B, and people learn to use it well. Depending what someone's goals are, the physiatrist, the doctor, will write a prescription to try and match the goal versus the prosthesis. For instance, if somebody plans on returning back to a farmyard and working as a farmer, their needs for an artificial leg may be totally different than somebody who just wants to walk in the kitchen.
In order to shape and prepare your limb for prosthesis, you'll need to position your limb correctly and use some kind of compression. A common way to compress the limb is to use a double, triple, or even a quadruple length tensor to wrap the limb in a crisscross manner from the bottom to the top. Compression helps to support the tissues and helps with pain, wound healing, and shaping the limb so that it can fit into an artificial leg. The tensor wrap should be removed and reapplied 3 to 4 times a day to ensure it is not shifted, to avoid skin issues, and to do your exercises for joint flexibility and strength. For more in-depth instruction on wrapping, you can go to the St. Joseph's Healthcare London website to view the correct methods to apply a tensor on a below-knee or an above-knee amputation. Once your limb is fairly well healed and it is the right size and shape, a prosthetist will make a plaster cast of the end of your limb. From that cast, a custom-fitted socket will be made, much like this. The socket is attached to an artificial foot using a pipe. You will apply various socks on your limb before placing your limb into the socket. The prosthesis is then attached to your limb using some form of sleeve or a liner as a suspension. You can expect to be standing and using your prosthesis within 2 to 3 days of casting. Our team will then work closely with you and the prosthetist to progress your prosthetic activities based on your skin, balance, endurance, goals, etc. Keep in mind that the rate at which you progress and the ultimate goals you have with the prosthesis may be quite different than those of other people you meet in our program. Some people get an artificial leg just to help with transfers, while others may return to sports activities, for example.
Depending on the size and shape of your limb and the degree of healing, another option is to use a product called TubiGrip. TubiGrip comes in different sizes. We find that a properly fitted piece of TubiGrip can accomplish the same goals as the tensor wrap, perhaps just more slowly. One advantage of the TubiGrip is you don't have to rewrap it every 4 hours. It's also easier to put on, and if it slips down, you can just tug it up instead of rewrapping. The TubiGrip stays on, aside from dressing changes, skin checks, or washing. The TubiGrip is tugged up onto the limb, extending above the knee for a below-the-knee amputation, with the top edge lying flat. TubiGrip can be applied with 1 or 2 layers. If using 1 layer, have a knot in the bottom end and tug the TubiGrip up until there's not a gap at the end. If putting on 2 layers, the TubiGrip can be twisted a half turn and then turned back onto itself, like this. Notice that the second layer is shorter than the first, so the end of the limb has 2 layers. The knee has 1 layer, and the thigh has none. This can help move fluid up the limb. If you have a hard time with the twist, an elastic can be used, like this. Here's the coffee can prepared to apply 2 layers onto the limb. Remove the can. Slide things up nice and smooth. Do your twist and extend back up. Your rehab program is Monday to Friday. It works best when someone's already living in their home or final discharge destination before being admitted for a prosthesis, since you'll be expected to go home each weekend to practice what you've learned. You typically go home on Fridays late afternoon and return Sunday evening. Learning to use the artificial leg will take on average 3 to 4 weeks. Once your inpatient stay is complete, you'll be discharged home with an appointment to see us in clinic in about 6 weeks' time. You'll be seen in follow-up frequently in the first year with the prosthesis.
Once you start to use your prosthesis, your limb will continue to change in size and shape. We will teach you how to adjust the fit to avoid pain and skin breakdown. We'll work with the prosthetist to adjust the alignment of your prosthesis as you progress onto different gait aids. Your limb will continue to change after discharge from the program, and it will be important for you to maintain contact with our clinic and your prosthetist. Most people will need more than one temporary socket before the limb is stabilized in about a year. At that time, a definitive socket will be prescribed.
As Peter mentioned earlier, the artificial leg helps your leg to continue to shrink as you're using it. He talked about shrinking out of the first socket, requiring a second socket, and sometimes people need a third temporary socket because maybe they've got a lot more fluid to lose. Before eventually a year down the road, he used the term definitive socket. That journey is about a year.
Equally important as an artificial limb is a properly fitted wheelchair. ADP may help to pay for the cost of a wheelchair. Even when someone is successful with their prosthesis, the amount of time that they wear it will be limited. At the time of discharge, we will recommend a wearing schedule, such as wearing the leg 3 times a day and only 2 hours each time, in order to let your leg build up tolerance. There will also be times when you can't wear the leg or it is in the shop and you will need a safe way to get around. Before you leave the hospital where your amputation occurred, there ideally should be some basic features in a wheelchair that you need. First is an amputee board and pad. The board goes underneath the cushion on the wheelchair, and the pad comes up like this. You don't want your limb to be hanging because it can make it more difficult to shrink and shape. You also don't want your leg to be continuously bent because that can make it more difficult to straighten as well. It is also recommended that the wheelchair have anti-tippers. With the loss of the limb, there is less weight at the front of the chair to counteract the weight of your torso in the back of the chair. So when going up any inclines, there is the risk for you to tip backwards. Anti-tippers prevent this and increase your safety. Ideally, you will need both footrests on the wheelchair. We encourage you not to foot propel in order to protect your other leg, so you will need both footrests. You will need the second footrest to support your prosthesis once you are fitted. We recommend that everyone take advantage of the Assistive Devices Program, or ADP, to get a properly fitted wheelchair. This is a funding program where a portion of the wheelchair will be covered through the government. If you are able to start the process with an occupational therapist in the community, that's great. We just like to have some input on the wheelchair before the paperwork is submitted to see how it fits with the prosthesis. Depending on the type of prosthesis and other factors, the wheelchair will be specific to you. It can be difficult to change your wheelchair prescription once it has been finalized and approved by ADP.